We shall start the class now. So today topic is clinical pharmacology, toxicologies and poisoning. And the speaker we have here is Dr. Asif Iqbal, who is a HOD Respiratory Critical Care and ECMO Services at Apollo Multi-Speciality Hospital, Kolkata. Thank you, sir, for being with us. You may start.
Good evening, students. Today I will take classes on the clinical pharmacology, toxicology, and the poisoning. It's a huge chapter. This is not a one day next to impossible possible to finish. So I will take this subject in 3 class because it is a very important subject for the MRCP part 1 and the part 2, and also you will get lot of question in MRCP part 1. You will get 20 mark question from the clinical pharmacology, 10 marks question from the toxicology and the poisoning. So you are understanding that the total 30 marks question will come in particular this segment. And this segment is basically very if you know the answer, you will get the correct mark, or if you don't know, then and it easy to get scored in this particular area because the pattern of question is very similar. So if you know the pattern, you will be able to give the answer. So now coming to our first question. And before starting this, regarding the clinical pharmacology, you should remember the area where from the question come. The first area, that is your basic pharmacology, like drug metabolism. There are a lot of questions will come from the drug metabolism, and you have to read thoroughly about the cytochrome P450, because there are a lot of question coming from the different type of question will come from the cytochrome P450. And also you have to have knowledge about the phase 2 and phase 3 reaction, and also you have to have the knowledge on the drug excretion and the drug interaction. The most of the question on the pharmacology, that is depend on the drug interaction and the side effect, adverse effect of the drugs. So though it is called clinical pharmacology, but the question will come from the respiratory drugs, from the cardiology drugs, from the antipsychotic drugs, from your chemotherapeutic drugs. So, though it is a clinical pharmacology, but you are getting the drug interaction of the adverse reaction of different system wise. So let's come to our next first question. That is 19-year-old woman presented in the emergency department. She had row with her boyfriend and took a handful of her mother tablet, which she found in the bottle. And her mother has multiple health problems, including hypertension, reflux esophagitis, dyslipidemia, night cramp. The patient complained of involuntary spasm affecting the left side of her neck, particularly sternocleidomastoid, and feel very upset. On examination, her blood pressure is high, 155 by 90 mm. Which one of the following the drug which most likely have taken? So this question particularly asks about your this question particularly asks about the side effect of one of the drugs. So your key point in this question, one is the involuntary spasm and other is the sternocleidomastoid, particularly sternocleidomastoid. So any one of our aspirant can tell me what problem she is suffering.
Yes, the answer is metoclopramide, and
Why?
most likely due to EPS, extrapyramidal syndrome. Most likely.
Very good. So this is the involuntary spasm and the sternocleidomastoid is the features of extrapyramidal syndrome, and particularly the sternocleidomastoid is the very specific for your sternocleidomastoid spasm is very specific for the first sign of the extrapyramidal syndrome. So she is suffering from the extrapyramidal syndrome, and metoclopramide is the causative agent. So what other drugs which cause extrapyramidal syndrome? So you are right. So what other causes of extrapyramidal syndrome? So extrapyramidal syndrome is a symptom that are typically associated with extrapyramidal system of brain cerebral cortex. This include movement dysfunction such as dystonia, continuous spasm of muscle contraction, akathisia, maybe manifestation and motor restlessness, Parkinsonism, characteristic symptom. This sometimes is mimic like a Parkinsonism, rigid bradykinesia, tremor, and tardive dyskinesia, that is irregular jerky movement. So causative agent, the most common typical antipsychotic associated with this extrapyramidal syndrome is haloperidol or fluphenazine. Other anti-dopaminergic drug like metoclopramide, and short and long-acting use of antidepressants such as selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, norepinephrine dopamine reuptake inhibitors. So most of the antipsychotic drugs, they do cause the extrapyramidal syndrome, and non-medication related extrapyramidal syndrome, like if the patient suffering from meningitis. Now, what is the treatment of extrapyramidal syndrome? The treatment varies with the type of symptoms. Like if there is a severe spasm, then anticholinergic has a good choice of drug. If there is a dystonia, anticholinergic. If there is a akathisia, then beta blocker like propranolol are frequently used to treat akathisia, and other medications sometimes used include clonidine, benzodiazepine, and pseudo Parkinsonism, because it's a symptom mimic like a Parkinsonism. So pseudo Parkinsonism is a then the drug of choice is anticholinergic and amantadine. So the patient who are getting long-term antipsychotic drug, they might mimic like a Parkinsonism symptom. So you have to think about your think about the extrapyramidal syndrome. Now coming to our next question, that is 43-year-old woman with a long-term history of manic depression psychosis come to emergency department, and she has nausea, diarrhea, lightheadedness, feel weak and lethargic. Her lithium level
Excuse
is
me, sir.
excuse me, yeah, is measured 2.5 millimole, and recent history noted that she has begun course of metronidazole for dental abscess. Which of the following most likely cause of her lithium toxicity? So this patient, psychotic patient on lithium, and now he developed lithium toxicity because you are now anyone can tell me the what is the normal level of lithium in the body?
1.5.
1.5, 1.5 to 2. Okay.
Right,
So
right.
it is also called narrow spectrum, narrow therapeutic window index of this drug. So the patient develop lithium toxicity. Now, what is the exact cause of lithium toxicity in this particular patient?
Most likely reduced renal clearance.
Yeah. So metronidazole cause metronidazole cause reduce excretion of the lithium through kidney. So what other drug causes the decrease excretion? One is non-steroidal anti-inflammatory drug, include cyclooxygenase COX-2, AC inhibitor, angiotensin 2 receptor antagonist, thiazide diuretics, corticosteroid, tetracycline like antibiotic. They also decrease reduce renal clearance. Now, lithium toxicity, one of the important area of your MRCP part 1 question. So you have to know about the lithium toxicity. So lithium toxicity means lithium overdose. Symptoms include tremor, increased reflex, trouble walking, kidney problem, and altered level of consciousness. Some symptoms may last for year after level return normal, like serotonin syndrome. Lithium toxicity can also occur due to excessive intake or decreased excretion. Excessive intake by either by suicidal in nature or accidental, and decreased excretion may occur result of either dehydration, such as vomiting, diarrhea, and low sodium diet and kidney problem. And the diagnosis is generally based on symptoms supported by lithium level. Usually, 1 to 1.5 is the normal range. If it is more than 1.2, you might have the develop sign symptom. The treatment, acute treatment is gastric lavage. Whole bowel irrigation may be useful in done in early. Active charcoal has not effective. So if the question have active charcoal, then it is not, you have to give the not effective treatment. And for severe toxicity, the treatment is hemodialysis, and risk of generally low in the lithium toxicity, and acute toxicity generally has better outcome than the chronic toxicity. So chronic toxicity happen when it is contaminated with water or in a long-term use of lithium for bipolar disorder.